Good afternoon. My name is Caitlin Takahashi. I'm a third-year general surgery resident at East Carolina University. I'm pleased to be here to present our study comparing laparoscopic and robotic gastrectomy for adenocarcinoma of the stomach. I do not have any disclosures. So gastric cancer is the fifth most common cancer and third leading cause of cancer worldwide. It is the mainstay of curative treatment is surgical resection. Furthermore, minimally invasive surgery has demonstrated improved perioperative outcomes such as shorter lengths of stay, better pain control, and overall decreased morbidities. It also has been demonstrated to have equivalent and sometimes better oncologic outcomes. The development of robotic surgery has the advantage of minimally invasive surgery with the added benefit of increased operative capabilities such as three-dimensional visualization and 7 degrees of freedom. Last year there were two studies, two randomized controlled trials that were published comparing robotic and laparoscopic gastrectomies. The first one was published out of Japan demonstrating increased operative time, but it did demonstrate an overall decreased perioperative morbidity. The second was published out of China, and this one looked specifically at distal gastrectomies. They found that the robotic gastrectomy group had increased lymph node harvest for extraperigastric lymph nodes, and also they demonstrated a decrease in perioperative morbidity. However, most of the studies comparing robotic gastrectomy are coming out of Asia, where the incidence of gastric cancer is higher and the institutions are having higher volume. And so there continues to be a knowledge gap here in the United States. So we aimed to evaluate the outcomes of robotic versus laparoscopic gastrectomy in the United States by looking at oncologic outcomes, perioperative outcomes, mortality, and survival. The data was pulled from the National Cancer Database on all patients who underwent gastrectomy between 2010 and 2017 for gastric cancer. There was a total of 39,000 cases, 10,700 were laparoscopic, and 2,500 were robotic. The remainder of them were open. Both the laparoscopic and robotic groups were similar in age, sex, and Charlson scores. Both had similar rates of types of gastrectomy, as you can see here. The majority underwent partial or subtotal gastrectomies at 54.3% and 57.2%. The notable difference between the two groups was the neoadjuvant therapy, where it was received in a higher number of patients in the robotic group at 40% compared to 30% in the laparoscopic group. The tumor characteristics were also very similar. The majority were located in the body, fundus, or cardia. There was no significant difference in the tumor histology grade or tumor size, and the majority of the pathologic stages were stage 0 to 1. There was no significant difference in the length of stay, 30-day readmission rate, or 30-day mortality. However, we did find that laparoscopic cases had more than doubled the rates of conversion to open than robotic gastrectomy at 15.2% compared to 7.2% in the laparoscopic group. And we also found a slight decrease in the 90-day mortality in the robotic gastrectomy group as well. The robotic group did demonstrate improved oncologic outcomes. Although the differences were small, there was a slight higher lymph node yield in the robotic group. And more notably, the surgical margins were more likely to be negative in the robotic group at 92.8% versus 89.9%. Multivariate analysis further demonstrated that age, sex, Charlson score, location of the tumor, tumor grade, pathologic stage, and operative technique were all predictors of survival. When we performed a survival analysis, we found that although robotic surgery had lower median survival by about 5.5 months, the robotic group had a better 5-year overall survival at 61% versus 58% for the laparoscopic group. And then for stage-specific survival, we looked, and the robotic and laparoscopic approaches in the stage 0 to 1 and stage 2 did not really find any significant differences in the median overall survival. If you look at the stage 0 to 1 and stage 3, there was a slight improvement in the 5-year overall survival in the robotic surgery groups. We conclude that although both robotic and laparoscopic approaches to gastrectomy are appropriate, the advancements with robotic surgery has demonstrated improved conversion to open rates, higher lymph node yield, and improved R0 resection rates. And we believe that there needs to be future studies on robotic gastrectomy in the United States. I'll take any questions.